couple minutes to log on and catch up and see that you're here. When you do join, if you're watching live, you'll see a little red dot that shows you're live. If you do not see a little red dot, you are not live, and that's okay because replays are the best thing ever right now. When you do join, we would love if you would comment in the comment box to tell us where you're watching from. We love getting a feel for where our viewers are. And we hope everyone's being safe and healthy and staying sane to some sort of level. We do have a very important guest tonight. So I want to give everyone just a minute to hop on. Hello, happy Sunday, Savannah. Hope everything's going good down there. So tonight we are joined by a researcher out of Dana-Farber. His name is Dr. Coleman Lindsley. He is working on a very important SDS project, if not more. I feel like researchers are kind of the hidden talent behind a lot of the big ideas that come out or therapies. So he is here to present what he would have presented this year had it not been a pandemic. So I will let him take it from here. In the meantime, please type in your comments in the question, or type your questions in the comments so we can get them answered at the end of the show for you, because we want this to be for you. So take it away, Dr. Lindsley.
Can you hear? There we go. I'm unmuted. Well, thank you very much for the invitation to join the group this evening. I'm going to share with you all some of our research that we've been focused on over the past several years, and I think in terms of our overarching goal, as with everyone here, we want to cure all of our patients with Schwatzman-Diamond syndrome. We want to find therapies to improve the quality of life of patients, and that is some of our next steps for us and others. Until we have better therapies around, I think our best chance at improving outcomes in patients, specifically around the challenge of leukemia, is to identify cancers, leukemias, before they happen, and intervene or intercept them and treat them before they become more difficult to treat. So what we've known over the past several years, and this is a topic I'm going to address head on with everyone, is that P53 is a central challenge to patients with Schwatzman-Diamond syndrome, with specific regard to the risk of developing leukemias. And by that, I mean specifically mutations affecting P53. And this is in studies that both our group and others have found, that leukemias that arise in the setting of Schwatzman-Diamond syndrome frequently carry acquired mutations in P53. And even some patients who don't yet have leukemia have mutations in the blood that have been acquired in this gene. But what we don't know is what do we do with that information? What does it truly mean when we look at a large number of individuals over a long period of time? Are there other gene mutations that we need to pay attention to? And how can we implement what we learn in the research setting into clinical care that directly improves the lives of patients and families affected by SDS? So I'm going to talk about, go in two stages this evening. First is going over some of the science. I'll start with some background about SDS that's relevant to this discussion, and really get into the nuts and bolts of what we try to do, what we found, and where we might go from here. And then I'll pause that, and we can talk about questions you might have, or translate some of the scientific data into language that that is more accessible. So I'm going to share my screen, and then we can start. So as I said, my goal is to, or what I'll talk about today is the results of our recent research. Second is what are the implications for patients and families, and then I'd like to talk about our next steps. And so, as a specific background for this conversation, I'm just going to go over some information that most people on the call here likely know very, very well. And so SDS is a disease of impaired protein translation. And this is due to a defect in how ribosomes mature in the cell. And it is caused primarily, though not exclusively, by mutations in both copies of the SBDS gene, as well as occasionally in the EFL1 gene and a couple other genes. And so normally, one part of the ribosome is formed in the nucleus, where it binds to a very important protein called EIF6. You just lodge this in the back of your mind for a few minutes. And this so-called 6DS ribosome bound or in partnership with EIF6 is sent out into the rest of the cell. And EIF6 is it blocks the formation of the mature ribosome, which produces proteins. And so the key function of SBDS, which is mutated in the disease, is to kick off this EIF6 protein and allow the two parts of the ribosome to join together and form the active mature ribosome that generates all the proteins that the cell relies on for its normal function. In SDS, the deficiency of the SBDS protein causes an inefficiency in kicking this EIF6 protein off of this nascent or partial subunit of the ribosome. And this results in an accumulation of these immature 6DS ribosomal subunits and a deficiency in these mature ribosomes, and that causes a defect in protein translation. This defect in protein translation is the root of the bone marrow failure and low blood counts and many other consequences of SDS. And it causes the normal activation of P53, which is the mechanism of the low blood counts. And so this risk of leukemia is really the challenge that we are trying to tackle. And right now, this risk of leukemia, we pursue clinical surveillance, and this depends on monitoring blood counts and performing bone marrow examinations and identifying early changes under the microscope that raise suspicion for an evolving leukemia. But that test is very insensitive, and right now does not give a precise picture of what's going on. And so what we did to tackle this problem is we sought to identify all of the acquired gene mutations that might cause leukemia in Schwatzman-Diamond syndrome. And we partnered with the SDS Registry, and as a result, partnered with the entire community to tackle this problem together. And so we used a tandem approach, or kind of a two-step approach, where we looked in what we call a discovery cohort, where we did full sequencing of bone marrow cells from patients, from almost 30 patients. And they had, some had AML, some had pre-leukemia called MDS. A couple had severe bone marrow failure. And then half of the group had no marrow failure, MDS or AML. We then identified all of the acquired mutations in this group of patients and then looked more broadly at the entire available set of samples from the registry, which was 110 patients with SDS. And this was from all the samples that these 110 patients had offered to the registry. So it was 327 different samples. And this was about 100 patients with SBDS mutations, one with DNAJC21 mutation, and then 11 without who had the clinical features of SDS, but without a known germline mutation, or so-called SDS-like disease. And the first answer we got was that P53 really is the predominant pathway of leukemogenesis in patients with Schwatzman-Diamond syndrome. So we found typical gene mutations that we find in MDS and AML in Schwatzman. All of the AML patients, patients who had developed AML, had detectable P53 mutations, and a good number of the MDS patients. This wasn't the surprise. On the other side, though, we looked at all of the patients who had not had leukemia, and we found that more than 70% of patients with genetically confirmed SDS have detectable mutations in the blood that have been acquired after, likely after birth. And in contrast, none of the SDS-like patients had any detectable mutations. So this really seems to be a phenomenon found in the SBDS and DNAJC21 mutated patients that we studied. And so this was more the rule than the exception. And when we looked at some of the other characteristics of these acquired mutations, and we'll call that clonal hematopoiesis. Hematopoiesis being the process of forming blood, and clonal being when a single stem cell has acquired a mutation and contributes in a disproportionate way to the blood that's circulating. And so clonal hematopoiesis, or CH, is a phenomenon that is associated with age, even in the absence of SDS. But what we found in SDS is that about 60% of kids under 10 had detectable clonal hematopoiesis, 90% of the teenagers, and every patient who was an adult or over 21. And so this appears to be a ubiquitous process that occurs precociously in SDS compared with the general public, where it is this sort of frequency occurs in the 60s, 70s, and 80s, and upwards of 90 years old. And even more strikingly, the actual genes that are mutated are very different. And predominantly, there are two genes that we found mutated most commonly, and those were EIF6, you remember that from the introduction, and P53. And then the genes that are typically associated with this process, called clonal hematopoiesis in normal non-Schwatzman individuals, are absent, and these are genes called DNMT3A and TET2. So this process appears to be very different in SDS patients compared with others. Happens younger and with different genes. The other thing that was very important to recognize is that many of these mutations, many of these individuals have not just one mutation or two, but upwards of 5, 10, or even 15 different mutations detectable in the blood. And so this raised some very central questions for us to tackle. And so, but I first want to get into is, what are these EIF6 mutations? We've all heard, or many of you have heard about P53 mutations, but the most common mutation in patients with Schwatzman-Diamond syndrome is EIF6. And we found this in more than 60% of patients. And so if you remember from what I said at the beginning, EIF6 is a protein, and here I'm showing you in yellow, and it's just a little cap on this ribosome subunit in teal, and this blocks, as I mentioned, blocks the joining of the rest of the ribosome right to that spot. And so what's really important is for this cap to be removed by SBDS. And so when we look at all of the different mutations, and we found 270 some different mutations in EIF6, some of them happen very frequently. So some specific mutations right here, this one called N106S and this other one R96W, are found in 20 and 16 different patients, respectively. The key thing that we found that these mutations do in Schwatzman cells, they either disrupt that binding of EIF6 to the ribosome, and in so doing, they allow the ribosome to mature more readily, or they are knocked out. And so it's called haploinsufficiency, or there's only half of the amount of EIF6, and this also allows the ribosome to join more efficiently. And so really this overarching mechanism or way that EIF6 mutations work in Schwatzman-Diamond syndrome is here. They cause the cell to have improved or rescued ribosome joining defect. And so the fundamental problem of Schwatzman SBDS deficiency is repaired by these EIF6 mutations. And as a result, we actually proved that these mutations improve protein translation in the cells that carry these mutations. And as a consequence of that improved ribosome joining and improved protein translation, there is less P53 activation. And this is beneficial to the survival of the cell. Remarkably, we found no MDS or AMLs that had this EIF6 mutation. So it appears, and I'll describe this a little bit later, to be compensatory or adaptive to the underlying problem. And this is in sharp distinction to what we found when we looked at the P53 mutations. These mutations don't rescue the ribosome defect. And so that the problem with protein translation is still present. But they cause the cell to survive inappropriately by clipping off the normal P53 activation. So EIF6 mutations and P53 mutations have the same effect at decreasing P53 activation, but they do it by different ways and with different consequences, all driven, though, by the same underlying problem in the cell. And you may ask, we find multiple mutations in the blood of individual patients. And so there are two ways that this could work. One is that one stem cell here, represented by one of these gray circles, one stem cell develops a mutation, and then that develops another mutation, and then another and another, and they are kind of like the Russian dolls. They develop what are called subclones and evolve. In another model, the one on the right, model 2, the bone marrow is unhealthy, and many different stem cells develop mutations of different sorts in parallel and have a limited evolution. And so in one sense, it's a single stem cell that evolves in a complex way. In the other model, it's many cells adapting to the same pressure. And so what we did is we took samples from 6 patients with many different mutations at different levels, and we actually looked at single cells. And this, I know, is a complex way to show it, but what this tells us is that this individual sample had 1, 2, 3, 4, 5, 6, 7, 8 different mutations, but they all were present in different cells. And so if they were the model 1, they would all be across the top row, but they're all in different groups of cells. And the same is what we found in every patient we looked at, is that these cells, and here I'm showing you 8 different EIS6 mutations on the right, they're in 8 different clones or 8 different cells. And so this bone marrow has found 8 different ways to repair the underlying Schwatzman defect in the cell. And then there is one P53 mutation, which is separate from these. And this is the rule that we found when looking at these samples. And you can ask, well, is that just a snapshot? What happens over time? And this again was one of the, I have to say, one of the visionary advances in the field was the creation of the registry and the participation of the community, where we have each arrow here is a different sample from a different individual, and we were able to track the abundance of the mutations and whether they changed or evolved over time. And so what I'm showing you here is that most mutations are generally stable over many, many years. And so here I'm looking at different ages. We're talking 5 to 10 years of time. Most mutations do not change in abundance. So they stay at a generally at about the same level, even the P53 mutations. And what I will tell you very clearly and very definitively, the presence of a P53 mutation is not a marker of impending leukemia. And I can't say that more clearly than that. And it is a very important conclusion that we did not know before, and we could not have known without the registry and the participation of the whole community, and being able to track these these samples and these mutations over long periods of time. And so I'm just going to leave that just for a moment so we can have keep that in the back of your mind. But you'll recall that I said at the beginning, of the leukemias we found, that P53 does appear to cause trouble. And so we looked at the characteristics. If I'm telling you that they don't change over time and it does not mark impending leukemia, what is it about them that does change them and make us worried? And so the answer to that is also quite clear from our study. And you don't have to understand what these plots show, but we were able to find that only the cells that acquired mutations in both copies of P53, so the cell has one copy from each parent, and in order to drive a leukemia, we found in each case that there was a mutation in both copies. Virtually all the P53 mutations that we found in patients in the registry were single copies. And so they did not have that characteristic. And so what we have is an overall model for how acquired mutations work in Schwarzman-Diamond syndrome. So first, this is kind of a cartoon that I'm hoping is engageable. And so in normal non-Schwarzman bone marrows, the stem cells are very fit. With the SBDS mutations, the cells are less fit. They have stress in the ribosomes, and they trigger dysfunction. Now the cell, this is kind of evolution in the bone marrow, and so any way that the cell can repair that lack of fitness, most commonly through an EIF6 mutation, whether it be the kind of mutations that we found, or through deletion of 20q, which is a common chromosomal alteration. We found that this improves the health or fitness of these clones and is an adaptive or compensatory process. The other pathway is where a single P53 mutation causes a cell to have improved fitness, but itself has limited potential for generating leukemia, and it is only with the mutation of the second allele or the second copy that the leukemias that we found developed. And so what I will leave you with here is that clonal hematopoiesis, or this process of single stem cells giving rise to more disproportionate amounts of the blood than others, is ubiquitous in Schwatzman-Diamond syndrome. I will also say that mutations themselves, or acquired mutations, are not necessarily bad, and in some cases, like EIF6, may actually be beneficial to blood cells. And then the third point is that P53 mutations themselves are not a marker of impending leukemia, but it raises questions for us. Can we integrate what we've learned into a rational strategy for surveillance? So can we identify these higher risk clones with the 2 copies of the P53 mutations earlier, and then provide more focused treatment? And so in this sort of a rational approach, we would, using this sort of rational approach, we would identify these compensatory mutations or low risk P53 mutations and continue to pursue surveillance. If we identify these, sorry for the term, but this is a LOH, is a loss of heterozygosity, or it's these 2 copy mutations, that would be a time where right now we would either, we could frequently reassess or trigger further discussions with a Schwatzman expert hematologist. And so what we did as a proof of concept is that we identified a leukemia that had this alteration, this P53 mutation on both copies. And we then traced back using available samples, and we said, well, how early using this advanced or single cell approach might we be able to detect? And so in this and limited other cases that we've been able to study, it's something that evolves not over weeks, not even over months, but likely over years. And so offering a potential window for intervention. And I'll emphasize that this is a work in progress, and that we still need to gain confidence in the right strategy for how to undergo or undertake surveillance. We need to determine what are the right interventions and with what timing. And this is a process that through collaboration and community participation in endeavors like the registry, we will together, I think, get there faster. And so, and this is really the last thing I'll show you, but I would encourage everyone in the community to participate in the registry, not just with the information sharing about the diagnosis and the outcomes and the symptoms, but also contributing samples so that we can continue to learn and develop new approaches and treatments. And then the other side is identify experts who are clinical experts who are experienced in the care of Schwatzman-Diamond syndrome patients who may serve as collaborators to help your local physician guide your clinical care. And so towards that end, we certainly have, there are folks at ours and many other institutions who can serve that role, recognizing the increasing number of patients who are now being diagnosed as adults and being followed into adulthood. We've started, where I recruited Chris Riley, who did research in my laboratory and is a clinical leukemia doc. He has taken on a role at Dana-Farber, which is focused on the care of adult patients with leukemia predisposition syndromes and bone marrow failure syndromes. And so he's working in tandem with Dr. Shimamura in the pediatric setting. And we're really trying to provide a continuity of care for patients as they age, but also as we identify more patients who are adults at the time of diagnosis. I know I took longer than I promised, but I'm going to pause there and answer any questions that you have or clarify anything I said that might have been unclear.
I think you did much better on time than I would have. So I think everything's totally fine. There's no worries on this end. We did have quite a few good questions come in, and I found myself sitting over here taking notes, because one of the most important aspects about our show, I think, is that typically Nicole is here and she has a genetic child and I have a clinical child. So we see both ends of the spectrum very differently. And I just wanted to ask one clarifying question before I jump into these ones. When you had said that you saw none of these mutations in the SDS-like community, when you say SDS-like community, is that anyone that does not have both mutations of an SBDS gene or one mutation? It's always kind of this weird spot to be in.
Yeah, and so I think what I will say is that this remains an incompletely answered question. And our first study was aimed at trying to answer the question as comprehensively as possible, but within the bounds of the funding and the samples that we had. So what I can tell you is that I was very interested in understanding this the SDS-like group of patients, but that was 11 different patients who did not. I don't believe that they had heterozygous SBDS mutations. The idea was to have not be carriers and not have an identified genetic cause of the disease, so that they could be as distinct as possible from the other group, but also enough of them to be informative. But that's certainly an incomplete area of the research that we would like to expand, because it's really unclear to me what the hematologic risk is in that. Yeah, in that.
It's always really hard because you have, truly genetic patients where there are two mutations, and then truly clinical SDS-like with no known mutations, I should say. And then this kind of weird gray area where you've got one, but they don't really know. And so it's always kind of, I just like to, I guess, reaffirm and get as much clarification as I can, just not only for me personally, but I know there's a lot of clinical families who would probably message us later. So let's jump into some of these questions. Okay, let me see if I can scroll back up. And I do want to reiterate, we do have a slide we're going to throw up at the end. If you are not on the SDS registry, we please urge you to join it. It is very important. My son just had his annual marrow, and he carried his little kit out, and he thought it was the coolest thing to see his bone marrow in a tube, and it helped really understand things for him a little bit more. But not only that, it's going to progress research so much. Okay, our first question is from Erica. I have 3 sons with SDS, one who is 6 years post bone marrow transplant. I'm excited about what this research may mean going forward for my boys. We just had our annual marrows and will be included in an upcoming batch of the single cell sequencing through the SDS registry. Moving forward, what is the potential for this testing to be used in clinical care and not be considered experimental? Whoa.
Yeah, that is the question that I'm glad that's the top line question, because it's my top line question. So we have several layers of testing, some of which is clinically available. And so I run the molecular diagnostics effort at Dana-Farber in hematologic malignancies, and we have a clinical sequencing test where we can detect the P53 mutations and other mutations that we might see in patients. The single cell sequencing is really a true frontier, and there is no example of a clinical single cell sequencing test that I know of. That said, it is my mission, and I have recruited the people in my lab to determine, to really try to push those boundaries and say, is this the opportunity to really push development of this sort of test with a clear directive? And so I don't have a timeline, but I can tell you that we are designing doing the technology development to prove the reliability and interpretability and validity of this testing for patients.
So what is the best way then? Oh, sorry, no, go ahead.
So that's it. But I think what you're asking, what I can imagine you're going to ask. Why don't you ask your question? I don't want to read your mind.
But what if it's really easy to read? And so not any average family can walk into a genetics office and say, excuse me, I would like this testing. It's only available through the registry currently. There's not a clinical test for it.
Well, it depends on, we can be clear about the types of tests. The single cell sequencing has only been performed in a proof of concept setting. And that has a lot that we need to focus on in order to prove the technology, but also prove the clinical utility. That we are focused on, and that we just need more. The more samples, the more information, and the more participation we can get from the community, the faster that we will be able to prove it to ourselves and to you that this is something that we can do. For the mutation detection, not single cell, that is something which is available outside of a experimental model.
Is that something that would be tested with a regular yearly marrow, or is that something that would have to be separate?
For the standard, what's called next generation sequencing test, or the DNA sequencing test, there are that could be done on an annual marrow, and it could be done at any of several institutions or commercial sites. I do encourage you, though, to have your results interpreted with you as a family by a team of people who are not only experts in Schwatzman and hematology, but also genetics. There can be a lot of misunderstandings, even among well-meaning and knowledgeable folks. So I just encourage people to have that either consultation or connection with an experienced center. The next question that often comes up is, well, will this ever be able to substitute for a bone marrow examination? And could this testing be done from the blood rather than from the bone marrow? And what added information is achieved by doing the bone marrow? And this, I will also say, is a human priority for our group. It's not the biggest scientific question, but it actually is an important human question. So can we perform non-invasive surveillance? And this is really a question Dr. Shimamura is extremely interested in answering, and I'm delighted to help her answer that.
I think one of my favorite things about Dr. S is that once she gets an idea, it's like, it's go, 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 go. She does not see hurdles or roadblocks. She's just kind of this tiny, amazing scientist beauty, like paving a way to get things. And I admire that about her. I think it's really great.
I'm fortunate to collaborate with her and with the community.
It's an experience for sure. The next one was Joan. I have heard that a large percentage of SDS patients have the PT53. At what point does the presence of PT53 become a cause for concern?
Yes, Joan, that's a essential question, and it is. Now we have multiple studies showing that P53 mutations are much more common in SDS patients than leukemia is. And the take home that I from our research is that you're suggesting here is that in and of themselves, not something for immediate concern, these mutations. What I would, and I think this needs more patients, more information, but when I see the levels, the abundance of that mutation increasing over time, that is something which would cause me to want to check more regularly, to find a donor for a possible transplantation. And so I would say right now, with the technology we have, the mutation increasing in abundance over time is, and I'm not talking like 1%, but many percent over time is the thing we can do. The other side is developing new tests, like I'm talking about these, where we can identify the second copy mutation. That would be where I would like to get with the community, is to be able to identify those.
The next question that came in right below, it kind of piggybacks on that just a little bit. It says, we stain annually for TP53. All of our results have come back with rare findings of less than 2%. Is there any reassurance in this, or is there a level that would be concerning enough to trigger us to push for the single cell sequencing?
That is something I think we would need to correlate our genetic data with the staining data. We have a pathologist at Boston Children's who is particularly interested in that sort of thing, but I suspect that the sequencing would be the most sensitive way to detect these things, and so I don't have data that help me answer that question right now.
The next one coming in was from Angela. It says, so with this being a possible surveillance test, is that like the regular cytogenics and FISH testing, or would this be separate?
This is separate, and I want to. We prepare the DNA and sequence it and look at the DNA bases in using a very different technology than cytogenetics and FISH. and it is more sensitive than either of those. And I will just emphasize again, I'm don't mean to emphasize it so much, but I want to share exciting potentials without, but also be clear that we still have a lot to learn before we can deploy the single cell approaches into to the care of clinical patients. And so that is, I just want to make sure that I'm communicating that.
No, it's very reassuring. I don't know if, I know we've talked P53 a lot between multiple guests who have been on, and I think this is the first time that it's been said, you know, that it's concerning, but to take a breath, you know, and that research is still going. So the next question is kind of a repeat of earlier, but maybe worded in a little bit of a different way, and so there might be a little bit of a different answer. It's from Stein. When finding the TP53 mutation in children with SDS, how many % findings should there be before one should be concerned? And then skip down just a little, and it says that his son currently has 6% mutation in bone marrow biopsies, but it increases a few percent at least every 1 or 2 year. I'm not sure if it's 1 or 2 year bone marrow biopsy or half year bone marrow biopsy. But at that point, when would you start thinking about bone marrow transplantation? And I think the answer is going to be kind of along the lines of what you said earlier, with there's a lot more factors that have to go into it.
Yes, I think there are a bunch of factors that we would weigh together, and I would certainly want these kinds of answers to come from a team of physicians who who have the experience in the right set of skills. It sounds so I think I would need to look at I would ask you to ask that question of your care team.
For families who need to, before we ask our last question, which I think is going to be a good one, not only can they go to the SDS registry website to get on the registry, which is a very important step in finding all of these answers for everybody, but is there a way to get in contact with the team there? We have many patients who are from out of the country, or definitely not near the Midwest or Boston area. I'm very lucky we are, but there's, you know, a lot who aren't able to get there. Is there a way to contact the team on the website?
With regards to how to specifically contact, I'm not sure how that works. I will say for sure that both in the pediatric and adult setting at Dana-Farber, we offer consultative review and clinic visits, and this is something which some people transfer their care, some people come annually, some people check in once just to get a review of everything, and all of those are we're happy to be a service to the community in that way. So I know that Dr. Shimamura and Dr. Riley will answer questions and set up clinic visits virtually now. It's actually one of the great things about the pandemic, is that we now have ways to see patients at a distance that we didn't have before. And so I think the registry can connect people to clinical care teams.
And I think as well, you can also contact your local physicians or your local hematologists and ask them to get in contact with Dr. Shimamura, Dr. Myers, someone knowledgeable in SDS who knows. At least for my family, what we do is we check in with Dr. Myers once a year, whether that's an in-person visit or via email, just kind of keeping tabs on it. And then she kind of, puts the ideas down for our local hematologist on what she would want and what she would do. And so then we do it all from home. So we don't have to travel 8 hours to do it, which I think, like you said, is one of the best things to come out of the pandemic, is that there's more access to doctors and shows like this and ways that we could never connect with people before. Which is kind of a crappy silver lining, but I feel like we have to find one somewhere.
Yeah.
So The last question we have is from Joan. Our goal is to always get a patient to transplant before leukemia occurs. Is it possible that this is the kind of research can help do that?
Absolutely. That is my number one mission, is to intercept the development of leukemia and cure it before it ever happens. And so that is my scientific and human goal with this research. Would be to never see Schwatzman leukemia again. And so that I'm hoping that through a deeper understanding of the biology, and then development of new tests, and then validation of those new tests so that we have confidence in how to use them, when to use them, might allow us to reach that goal that Joan is talking about here. And the other side is, I think there are therapeutic ideas that come from our research. And so is there a way that we can develop new drugs that mimic these EIF6 mutations that we found? And so we're exploring that quite actively. Are there non-transplant approaches that that might also be beneficial? Because I know transplant is a big step.
It's a big step, and it's usually if history serves, it's kind of a last step for a lot of SDS patients. I think anyone would try to go to a transplant, or to try to avoid going to a transplant if they could. And I know that's why a lot of the therapies we have are already in place, and it's very important. I think that's all the questions we have. Is there anything else you have for us, Dr. Lindsley?
I would just emphasize again my gratitude to the community for your partnership. And I cannot overstate how visionary the registry has been. I also study other predisposition syndromes, and it is really quite a resource and a measure of the commitment and love that the community has for their families and each other. And so the best thing that I hope for is that the registry and the community continues to cooperate in this sort of way, and just it continues to expand, send samples, send information, and you have, and so this research is really only because of the work of you guys.
And I think when in doubt, contact the registry. Ask them if they have your updated information. Make sure you're getting your marrow kits every year. Be sure you are filling out that really long patient update history, which I know takes 10 years, and sending med lists and letting them know about what's going on, because they're not mind readers and they don't always have access to our medical records like we think they do. So be sure you're giving them all the information that you can. Because it is a very vital resource for everybody. And we're going to put the link up at the end so you can find out how to get there and join up for yourself. I want to thank you for your time, Dr. Lindsley. I know there was a lot of miscommunication. There was some errors and everything worked out totally fine. And kids are maybe asleep. We don't really know. And I know it took time away from your family. And it is really important to us in the community that we did get this information out there. So I do want to thank you for your time tonight.
You're very welcome. And thank you for the invitation.
Yes, have a great evening and stay safe and warm and wear a mask and wash your hands and I don't know, everything everyone else says all the time.
Thanks.
Thanks
Bye.
for everything, Dr. Lindsley.
Bye-bye.
And thanks everyone for joining us tonight. I know it was kind of a late start, and I hope we got all of your questions answered. If we did not get all of your questions answered, please feel free to message me, drop them in the comments still. I'll double check in on them, email them to me. And I do just want to reiterate to please join the registry if you're not already on it. It's so very important. I'm going to let Orva put it. There we go. And I just want to leave you with this, that this is one of the most important tools that you can have in your corner. The registry is really, really, really a very vital piece of all of the research going forward and everything that comes out of this. So with that, I'm going to leave you with the link. I'm going to tell you to wash your hands, stay safe, wear your masks, stay in contact with people. Do not isolate yourself from humanity in such a way that you can't even message someone, and have a great night.